So are we ready?
Yes, sir.
Right, so we'll just start in a minute.
Yeah.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14P, which is Hematology General and Fundamental. We are streaming live from Medical College, Solan, Himachal Pradesh via Kolkata. A very, very interesting and very relevant topic, tales that histogram tells. Indeed, we all would really like to know what are the tales which the histogram tells. And to speak on that, we have none other than Dr. Naveen Kakkar, an expert in hematology, one of the national figures in hematology. Dr. Kakkar is an MBBS and MD from CMC Ludhiana. Presently, she is a professor in the Department of Pathology at the Medical College and Hospital, Kumarhatti, Solan, Himachal Pradesh, with key interest in automated hematological analyzer, coagulation testing, hemoglobin disorders, hemolytic anemias, and leukemias, with more than 83 publications in national and international journals. Before I ask Dr. Kakkar to start, let me request all of you, please keep your mic muted, your camera off, and please do not share your screen. With this, let me request Dr. Kakkar, sir, please share your screen. Let's start. We are good to go.
Dr. Naveen, can you confirm the screen is visible?
Yes, sir. The screen is visible and it's very clear and you're audible very clearly. Please start, sir. Thank you.
Okay, thank you, sir. So I would first like to thank Dr. Nadeem and Dr. Anita and everybody else whom I do not know at Neelam Pathology for inviting me for this and sharing whatever little I know regarding a topic that is close to my heart. So let's begin. Tales that histograms tell. The word histogram actually comes from the Greek word histo and gramma. And histo stands for mast. That's why the picture of the ship, the mast, and we know the towers of the histograms look like this somewhat, the lengths. And gramma is to read. So whatever we read or make sense of numbers, we present it in a data form, and that's how the name histogram is started. Now, we know tales can be boring, and the topic has tales, and they can be pretty boring actually. So I'll try to keep this interesting with less of theory and more of what practically I've seen, and if I can share that with you. So the outline of this talk, we'll discuss why this topic was chosen, a bit about hematology analyzers and how they work, especially the three parts, because that's what our focus is on today. What are these histograms? How are they generated? It is important to know this background to understand how they work. So a lot of people argue, why do I need to know how this machine works? Very, very important, because when it goes wrong or it gives you something unusual, unless you know the background, you will not be able to sort out. Then we look at histogram types, which is basically red cell, white cell, and the platelets. And my main thrust will be on three-part histogram patterns in common hematological condition. A disclaimer there that all of these, except probably one case, is from our own collection that we've seen. So it is nothing taken from the internet or any other source. What I'm not going to talk about today is 5-part scatter plots or cytograms, which are more complex and probably need another sitting to understand and relate to these 3-part ones. I'm not going to talk about flags at all, with at least a general overview at points where it is required, but otherwise flags is another story again, and it is dependent a lot on the kind of analyzer you use and also other instrument specific terminology. So if you have a 3-part or a 5-part or a higher end or 2 different 3 parts, you may have terminologies of interpretation that are given to you by the manufacturer. So I'm not going to go into that. We will cover broad areas that in general apply to most 3-part analyzers, and in fact almost also to 5-part to some extent. And I will cut down and minimize the theoretical jargon that you'll find in books on how these work and what are the interferences, and we'll talk about that, but I'll cut down that to a minimum. Now, to have an accurate CBC report, which is why our analyzers run all day and all night, We need the numbers, the numerical data that we are so familiar with. We need the histograms, we need the flags, and finally a blood smear wherever required, not all cases. But remember, for an accurate report, especially in cases which have some kind of an interference or a problem or a pathology, you require a good marriage of these four conditions, of these four parameters. You miss one or two, you can miss one or two findings also. And we are so used to numbers that we think the others are not important. But as you will see, many of these things point to a diagnosis sometimes that is not apparent on the numbers only. The numerical data is what we are so used to, and that everybody goes that way. But the graphical output is usually ignored, and that is going to be our focus, especially. And the message is we need to look beyond the numbers that we always deal with. Everybody deals with numbers day in, day out. We interpret them well, but the histograms add a new dimension to your interpretation. And sometimes, like I said, a new diagnosis that you were not thinking of earlier. Now, why this topic was chosen? Because I feel histograms and cytograms from 5 parts, 3 parts are poor cousins of number. There are lots of advancement on the numerical data with new parameters and flagging instruments capabilities have increased a lot. The graphical output with histograms, scatter plots, etc. is largely ignored. And this contains valuable information. Like I said, some plots are virtually diagnostic. You'll see 3 or 4 examples like that. And the key to recognizing these is pattern recognition. So you see one kind of diagnosis, see the second one of the same, the third printout of the same, the fourth. Maybe till you see about 50, 100 or more, you will start seeing the patterns. And pattern doesn't mean one pattern. You will have 3 or 4 patterns, even of iron deficiency, 4 or 5 of megaloblastic, and so on. So the more you see these printouts, the more knowledge you get, and the more value it adds to your report. A lot of people argue, I've got this instrument, you've got another one, so how do I figure this out? It really doesn't matter. If you're having a 3-part, whatever the make, general principles will still apply. Having said that, each analyzer has its own personality. So if I worked with a particular 3-part, I'll need about 4 to 6 months to kind of break in and then be friends with it, and to understand what it generates and why it generates and what are the problems that you encounter if there are sample interferences or some particular diagnosis. Now, I've taken a random 3-part analyzer and I'm naming it J. So if you have an analyzer which is 3-part, at least because the histograms that we're talking about is mainly 3 parts, and 3 parts are the ones most commonly used across labs, call your instrument J, and then you have to become its Viru. So unless you befriend your instrument, then that means getting off your chair, working in the lab with the technicians, with a problem sample, with a routine sample, with a classical diagnosis. Only then you get into the loop of understanding histograms. If you deal with printouts on your table, I can guarantee you this will take a long time. So a lot of people again ask, which analyzer works best? 3-part, 5-part, 6, 7 or 10 parts? Look at what they can give you. A 3-part gives you a neutrophil, mixed and the lymphocyte population. 5-part gives you all the 5 WBCs. 6 parts add atypical cells or large unstained cells. 7 parts adds fragmented cells, immature granulocytes next. And if I say 12-part, you'll think I'm joking, but there are counters coming pretty close to that or reaching close to that where they give you a breakup of 12 kind of cells. Now, I recommend for all of you this 2-part analyzer that is coming on screen with the left and the right hemisphere. If you use this, then a 3-part or a 12-part or a 10-part does not matter. We just need to learn to interpret what comes out accurately. So what are histograms? Let's look at how they are generated. Very simple. So on a RBC, WBC or a platelet histogram, what you see on the x-axis is volume. The numbers on the y-axis. So imagine, say about 50, 100 cells, actually more, about 10,000 cells go through the aperture quickly. And they have different volumes, they have different numbers. Some of them will have same volumes. So that number will be plotted on the y-axis and the volumes on the x-axis. So on a random run, this is what actually happens in an analyzer. You'll find varying volumes running through the analyzer, and it's looking at the number of those cells and their volumes and plots them randomly. Then the software adjusts them like this and prepares a curve for you. And that is how you get a histogram. And it's obviously as a Gaussian distribution. What about discriminators? Now here, it is important to understand that a normal histogram, for a to be normal, we must say, except for the limits that are set by the manufacturer, It starts at the baseline, ends at the baseline. That gives you confidence that there is no interference, your sample is run well, and it's a normal distribution of cells. The moment you get lifting of this part or this part, that's a platelet and RBC area, and this is for WBCs. You'll have the lower or upper discriminator being raised. Expect interference, expect an unusual diagnosis, and that's the thing to look out. One of the things to look out for when you assess a histogram. I'll just give you one example. That's an RBC histogram, and if you see, the ascending limb does not begin at the baseline, which means it is joining ahead with the platelet parameters coming there. The platelet histogram is interfering with that somewhat. So in this region, what could be the problems? There could be platelet clumps giving like to a large platelet size and spilling into the red cell volume area, red cell fragments which are small enough and interfering in the platelet area, giant platelets again falling into the red cell area, or microcyte, very very small red cells that are falling into the platelet zone. So what we look here is, look at it. This line should have actually touched the baseline normally for a normal distribution of cells. If this is not there, these could be the problems. And the problem may not be in this histogram or this cell line. This could be in the platelets or otherwise. Another word about moving thresholds. Now, to put it simple, threshold is a limit. So in a platelet histogram, the limit of assessment is almost 2 femtoliters to 25, right? And it goes till 30, but beyond that, beyond 25 here, the instrument is going to call the cells that it finds of this volume as red cells. Look at this histogram and this histogram now. And if you see, the limit is 25 here on a normal distribution of a platelet histogram, and it is between 20 to 25 here and 20 in the next one. Now, it is unusual that a threshold is moving, and that is why the term moving threshold. So basically, this is an algorithm fitted into the machine, fed into the machine, in which, depending on your cell population, the machine moves the threshold automatically. So let's say what is the problem here. Normal platelet size, very few giant platelets, tail ends, normal distribution. Here, your platelet histogram rises and never comes back. So large volume platelets, many of them, right? So very, very large volumes actually. So the instrument looks at this distribution of volumes as it assesses and decides that to assess this, I need to move the discriminator more to the left to avoid erroneous estimations. So it comes here. This one has again giant platelets, moves further in. So this is the concept of moving thresholds. When you're buying an analyzer or going for a reagent, please ask this. If they have a fixed threshold, you may have problems in samples which have a variable distribution. We had one issue with a thalassemia sample in which NRBCs were too many. So in that case, if there's a fixed threshold, your counts may be wrong all the time. So here, you need to find a counter. Most of the counters these days will have a moving threshold, which will adjust the threshold according to your sample nature or the nature of cells in your sample. Important. This doesn't mean it guarantees accuracy. We still need to correct this because the histogram is abnormal. We'll come to that later. That's a typical 3-part analyzer report. This is from ADVIA 60 that I have worked on when I started off looking at counters. So a lot of numerical parameters, the usual, and then your 3 histograms. We'll come to these again. That's a 5-part analyzer from ADVIA 120. And this again has histograms here. As you can see, more of red cell. You can also get WBC histograms there. But the point I'm trying to make is even 5 parts generate 3-part like histograms based on impedance. That's another 5-part from Beckman-Coulter, DXH800. Again, you have these complex scatter plots, but also the typical histograms that we are so familiar with. So let's look at how these machines work to generate these histograms or to count cells. The basis of any cell counting in any instrument. Wallace-Coulter, 1953-4, gave us this technology of impedance counting, based on which most of the counters still work. So what is the Coulter principle? You have the electrodes, external and internal. That's your aperture area. And from this, your sample, one cell passes at a time through the aperture. And I'll show you in the next few slides what this does to our counting. So the basis is, whenever we know the diluent is the most voluminous reagent that we have. So all your pipes or fluidics is actually bathed in the diluent all the time. Electrolyte solutions allow current to pass through them. So when the diluent is there, there is current across the electrodes, and the light bulb shows you current is there. Blood cells are poor conductors. Remember, the blood cells have a lipid membrane. So when in the circuit where you have the positive negative electrode based in diluent, so that conducts current, you have the light on, so to say. If you put in a cell in the circuit, the light goes off. The current is broken. If the current goes down, the resistance comes up, which is what we call as impedance, which is what we measure also. So take off the cell, the current comes back. Put in a neutrophil, current cuts off again. Now this is what will happen if a red cell passes through the aperture. So this is a magnified view of the aperture, positive and negative. You will see a red cell passing through this. As it passes, it generates an impulse in the oscilloscope. So you will see probably three sizes: large, medium, and small. And based on that, the impulses that you will see in this oscilloscope area will be small, larger, and smaller respectively. So bigger cell passes, big impulse; middle cell, small impulse; very small cell, small impulse. So the number of impulses is the number of cells that are passed, and the volume displaced, or that's equal to amount of impedance, is your volume of the cell. A neutrophil, bigger impulse; smaller cells, medium impulse; a lymphocyte, still smaller impulse. So that's how red cell and white cells are counted based on their volumes and the fluid it displaces in the aperture and the current it cuts and the resistance that rises respectively. So in these three histograms that we know, WBC, RBC, and platelets, if you spot the difference is the WBC histogram is very different, split into three zones. RBC and platelets are single. A common factor among red cells and platelets is that they are anucleate, as we know very well, and the WBCs are nucleate. Now, what is the basis of cell counting related to this? Because these two can be counted together. Because they do not have a nucleus, we do not have to treat the cytoplasm to estimate the nuclear volume and the cell volume. So WBCs go through a separate channel, that's a WBC channel. Your platelets and red cells, being anucleate, can be counted together. They go into the red cell/platelet channel. What's the hidden story inside the instrument? So although we see red cell and the platelet histogram as separate, inside this is what is happening. You have the platelet histogram actually overlapping with the red cell histogram, and they split it inside to give us separate counts. So we'll look at the volumes: 2 femtoliter to 20, and then RBC start with about 30. So 20 to 25 is still platelet zone, and then 30 onwards is red cells. So imagine this pool of red cells and platelets being counted together, and the instrument sorts the one with volume less than 25 as platelets, and the volumes more than 30 as red cells. So that's how it works out in the machine. Histograms are actually generated together and split into two for us for ease of cell assessment. Now what this means is that a large platelet can be hence counted as a red cell if it falls in this zone, and a red cell fragment which is small enough can be counted as a platelet. So these are the areas of interference, and we'll see some examples of these as we go along. Histograms or any scatter plot or cytograms are actually blaring out at us, please look at me. So it is important to look at them and understand them, to interpret them well, and then add value to your report. Anybody can interpret numbers, but you need skill and some experience for histograms. Once you acquire the basics, which doesn't take too long, you can actually master them very fast. I'm not reading this list, but as you can see, we're dealing with a good lot of common red cell disorders, a lot of WBC disorders commonly seen, and some platelet disorders that can be easily picked up on histograms, and some of them just diagnosed first time on a histogram. So I'll come back to the crux of today's talk, which is the histogram patterns in common hematological conditions. I've done a lot of comparison between normals or different patterns so that the end summarizes everything for you clearly. So let's look at red cell disorders first. That's again our normal histogram. If you look at, so now we'll focus on the red cell histogram. If you look at this histogram, rises here, that's where the mean is, drops in here. And remember, all of us have some macrocytic cells and some microcytic cells. That's normal. But the mean being normal of 82 is that tells us still a normal population. So now we're going to focus on a normality seen here related to the numbers. So let's look at case 1, which is you see a hemoglobin of 4, so severe anemia, gross microcytosis, MCV is 42, REW is 20, Doesn't require much to say this is classical iron deficiency anemia. You look at this histogram here, seems shifted very to the left. If I draw a line here, drops very close to 30, so that's 42 MCV. That's where it is dropping. So you can see the histogram is shifted to the left. Another thing to notice is while this is shifted markedly to the left, the platelet histogram seems to rise. And that is because your microcytes are so small, they are starting to come close to the platelet zone. So actually beyond this, your red cell pattern is rising here at the small volumes. So this will go together if there is good amount of microcytosis. So that's classical iron deficiency anemia, not too difficult to diagnose. So that's where your mean lies. That's your comparison with a normal histogram. So look at the position very clearly. If your mean is dropping here, this area is virtually empty. The entire histogram is moved to the left, classical iron deficiency. You also notice it's a bit broad, so there is good degree of poikilocytosis reflecting your high REW. The numbers will always match your histograms. Next case. What do we have here? Just mild anemia, but there is pronounced erythrocytosis. So for a hemoglobin of 10.6, you would expect 3.5, maximum 4 million RBCs, area of almost 6. So that's a clue. Then you move on to what is the type of anemia. You have gross microcytosis again, but with a completely normal red cell distribution width. And again, doesn't require much to say. This is beta thal carrier or beta thal trait. Again, because of the microcytosis, your platelet histogram shoots up because it's rising in this red cell zone now. The microcytes are interfering very close to the platelet zone. So this is classical thal trait. If you notice a difference between ID and this, we'll come to that. So beta thal trait. The next case is another beta thal trait. Similar findings, hemoglobin of 9, MCV very low, REW completely normal, and again a histogram shifted to the left with a low MCV. Again, a platelet histogram is rising in tune with the microcytosis. Third one again is a beta thal trait. MCV is 63, hemoglobin 12.3, RBC of 6.7. One misconception is that beta thal traits always have to be anemic. They may not be. In females and children, they may be, but in males, often you'll find hemoglobins of 12 to even 14 with gross microcytosis. So here, 12 hemoglobin, RBC count is high, MCV is 63, REW is normal. Again, a left shifted histogram. And let's now see a comparison between these three traits and a normal value. So that's your normal histogram. And if you look at all three beta thal traits are shifted markedly to the left. And if you draw a line from the mean, they are completely on the left. That's why MCVs are so low. But if you also notice their width, the width of the histogram is not as much as iron deficiency. Because the red cell distribution is normal, there is not much of poikilocytosis. Their RBC volumes are pretty close to each other. The next case, again severe anemia, gross microcytosis, but the REW is very, very high. Highest 28.3 is the, you can even maybe get about 22, 23, maximum 24 in a severe iron deficiency. 28.3 means gross and isopoikilocytosis. Is this reflected in the histogram? Yes, very much. It has become very wide. It shifted to the left, but very, very wide. So this is classical beta thalassemia major. This patient has lots of nucleated red cells, target cells, a lot of fragmented cells and poikilocytosis. Another thing to notice is this. Your platelet histogram doesn't seem to end at all. It's almost parallel, and it will join this part as you'll see in the next slide. There. So platelet histogram is seeing interference with the small microcytes, and if I put this on this side, this is where it joins and where the RBCs begin. So then you can see how they talk to each other in the machine. So a comparison of all of these microcytic conditions now. So you have normal one there. If you look at the line, there is a shift to the left in all of these histograms compared to the normal. So that's iron deficiency, that's thal trait. Very clearly the iron deficiency one is wider, thal trait is closer. That's where the REW here is higher, the REW here is normal. Beta thal major, the widest of them all. Very high REW. We've had cases where REW has been 28, 33, 35, reflecting the poikilocytosis that you see. And beta thal major on 3 parts is pretty diagnostic. We've got 3-4 more cases, exactly the same histogram pattern, same for thal traits. So this narrow tenting that you see close to the apex is typical. and this is microcytic but wider on iron deficiency. Next case, hemoglobin is 7.3, TLC normal, platelets are low, but MCV is clearly 114. Red cell distribution is almost 21, so that's classical megaloblastic features. And again, if you look at the histogram, this is your 100. So half of your population is beyond 100, giving rise to a very high MCV. Again, doesn't require much to diagnose this classical megaloblastic anemia. Let's again, like I said, majority of your population, 50% of that is beyond 100 femtoliters. Comparison, very, very clear difference, shift to the right and a broadening. Next case, MCV in the last case was, let's go back, 114. In this one it is 115, 115, but a normal REW. Hemoglobin is 15. So this cannot be megaloblastic anemia for sure because hemoglobin is so high, almost normal, almost it's actually normal for a male. This is a male patient. 15 is normal. So this is a classical non-megaloblastic macrocytosis where there is no B12 or folate deficiency, no macrovalocytes, no hypersegmentation, but your red cells are large. They've got excess of membrane material. So red cells are still large, REW is normal. You'll have uniform macrocytosis. In that case, again, red cell distribution does not go up much. So that's non-megaloblastic macrocytosis. If you compare the two, your megaloblastic anemia is very wide with macrocytosis. This has good degree of macrocytosis, but not that wide. So the peripheral smear here will show you uniform macrocytosis. Here you will see a good degree of poikilocytosis with macros, macrovalocytes, and so on. Look at the width, and the width here is much less. So although there is macrocytosis, but uniform, and there is non-uniform in megaloblastic. Let's not be mean. A lot of us are focused on numbers and we say MCV is so much, MCH is so much, and we go on comparing that. So let's come to one or two examples where the MCV does not seem to matter much or misleads. So look at this case. Hemoglobin is 10.7, so mild anemia. If you look at the indices, they are normal. So somebody will say nothing to worry, but I am worried about this number. Your REW is still high, while your MCV, MCH are perfectly normal. Now this REW tells me there is a varying population. Then why the normal values? So let's explore this further. If you look at the histogram, seems pretty wide. It's not a normal histogram, seems wide. We'll compare that. So that's dimorphic anemia. You have both populations, microcytic as well as macrocytic. There's a tug of war between these two within the instrument. So the microcytes will pull down your MCV, the macrocytes will pull up your MCV, and if they are in fairly equal numbers, you may get a mean cell volume or mean corpuscular volume, which is normal. That misleads. But the REW will not. So in this case, if you look at the same histogram here, the increased widening and on both sides, beyond 100 and close to 30 here, the widening here reflects microcytes as well as macrocytes. So if you look here, there is widening, so that tells you there's a mixture of population probably. And here you can see microcytes and a good number of macrocytes, along with a normocytic normochromic population. So these cells will pull up the MCV, these cells will pull down the MCV, and if they are roughly, because they are in equal numbers, you got an MCV which was normal. But the REW told you. Also, if you look at the REW being 20, your histogram is reflecting that rise with a varying population and a width that is increased. Another case where MCV is 95, still normal, indices are normal, hemoglobin is 5.7, seems like a normocytic normochromic anemia, but again red cell distribution is high, so you can see a widening on this side and a widening this side. This is again a dimorphic anemia. We have a third example where your macrocytosis is more pronounced. So if you see a good 40% of the cells are macrocytic, that's where MCV is high. So somebody can misinterpret this, looking at this as a classical megaloblastic anemia with a high REW, high MCV. But only the histogram here actually tells you that there is maybe a 1/4 microcytic population. So this actually was a dimorphic anemia with a predominant megaloblastic element, but also about 30%, 20% of cells being microcytic. So here, your numbers will tell you one story, but the histogram changes to a different. So histogram now will match with your smear. So the smear here definitely will show you microcytes along with the macrocytes. Just a comparison of all these. Normal, that's dimorphic again, and a wider dimorphic with microcytic population very clearly visible here, which was still starting to develop in this case and minimal in this case. Next case, hemoglobin is 10.4, MCV is 95, everything seems okay, but your MCHC is raised. The MCHC is a parameter which is very rarely raised. If it is raised, please look at it, might reflect something. So in this, your MCHC raised, and the history of this patient was intermittent jaundice with the mild splenomegaly. So we are thinking of spherocytosis with a raised MCHC. Remember, the MCHC may not be raised in all cases of spherocytosis. They have to be in significant numbers to affect this parameter. Here, luckily, the MCHC is increased and we suspect. So does the histogram show anything? Seems normal. The MCV is slightly on the higher side, so you have about 30% cells beyond the macrocytic zone. But if you look carefully again, there is a shoulder. There is a shouldering on the lower volumes. So the spherocytes are probably being plotted here as smaller volumes. So it is giving a hint compared to a normal histogram which starts like this. There is a small population. Coupled with an MCHC, this is a good clue. Remember, in spherocytosis, you may not get a high MCHC all the time. You may not get the shoulder all the time. That depends on the number of spherocytes. You were lucky in this case, it is showing this pattern. Now, most of the camels that we are used to have one hump. Now, in the hills, in some of the areas, this is a rare camel with two humps. And the histogram with two humps is also rare. But let's look at which condition. So here, hemoglobin is 8.7, MCV is 70, MCH is low, MCH is borderline, and the RW is very high, 28.2. And here is your camel hump. So if you go back to this picture, your red cell histogram has two humps, 1 and 2. So let's try and interpret this. What could be the problem here? If this was iron deficiency, as the MCV suggests, you would have seen one pattern shifted to the left. So here, and let me give you the diagnosis, it will be easy to discuss then. So this is a patient with recent blood transfusion. So what has happened here? Because after blood transfusion, his MCV is still 70, we can presume safely that before transfusion, MCV must be in the 60s somewhat, right? And this is what the curve that I am following on the cursor, this is how his iron deficiency pattern would have been. The one here, curve to the shift to the left. We gave him some transfused cells and they are plotted in the normocytic normochromic zone. Right? So that gives it the double lump. So this would have been a single iron deficiency pattern, but this is the transfused cell that is showing a separate population. Why is the RW so high? Because on one side you have microcytes, on one side you have normocytic normochromic cells. So much variation in volumes takes the RW very, very high. You give this patient about 72 hours to 4 days, 5 days, and these two populations will merge because your stored red cells that will be transfused gradually tend to become a bit spherocytic, or they are already spherocytic, and they'll merge. Only in the acute transfusion phase, they show up very differently. Next case, again, two humps, but here MCV is 113. So here, this patient was already a patient of megaloblastic anemia, and you transfuse cells which were normocytic normochromic, which are here. So on the last one, our transfused population is here. And on this one, I presume our transfused population is this one, the first one. So megaloblastic anemia with the transfused population. This is a patient on hematinics. Hemoglobin is 6.6, MCV is 70. But here the problem with the histogram is it should have come down sloping like this. So this additional curvature shows you an emerging normocytic normochromic population. So remember, this is in the microcytic zone still. That's why the MCV is so low. But this patient is on hematinics, and on hematinics the new cells have good hemoglobin, and they tend to fall separately because you have macrocytes and reticulocytes together. So they'll fall into mostly the normocytic or slightly macrocytic zone, and gradually as the population changes, this will merge and become smooth and normocytic normochromic. Now, chaos on the Indian roads is not new to us everywhere. A policeman dealing with a single scooterist is fine, but look at this one. This picture came about 1.5 to 2 years back, where this family used to travel on this road and was warned 5-6 times, and then one day this policeman did this. So imagine in our instrument, this is your aperture, and these are red cells. Let's go back. So in this case, the aperture can deal with one red cell easily, but aperture gives up when it finds 3, 4, or 5 red cells together. This is the problem we face when there is red cell agglutination. Your cell counting of the red cell goes awry, and that causes the problem. Let's see examples of those. So look at this case. This is actually a bizarre report. Let's see what is bizarre with it. One, the rule of 3 is violated. So your red cell count multiplied by 3 roughly should be your hemoglobin, which it is not. Your hemoglobin multiplied by 3 roughly should be your hematocrit. Again, not true. In fact, it is less. So there is something grossly wrong here. Hemoglobin here is actually accurately calculated because the red cells are lysed and spectrophotometrically estimated in the instrument. So the hemoglobin is estimated well, but your red cell and hematocrit is not because your red cell counting is a problem in this case. So the red cells have been undercounted, and we know that these three parameters are responsible for giving us the indices. So let's look at the indices. All of them are bizarre. The red cell is never below normal, never ever. It can be 11 or more, but never 3.8 or 7 or 9. So something is going drastically wrong. Let's go to our histogram. Histogram is more bizarre, almost sawtooth-like, right? Very, very bizarre, a spike here and irregular patterns going beyond 200 femtoliters. So this is a classical case of cold agglutinins, in which what does the aperture face? It faces red cell agglutinates. It can't count them accurately. One cluster passes off as one. So imagine 3 or 4 red cells passes off as one count with a high volume. All your calculations are wrong. Histogram is bizarre, but that is not the problem because this is actually your diagnosis. So if you have a case like this, you don't need to worry. You say we have a diagnosis coming up. The next step to do is keep the sample at 37 degree in a water bath for about 20 minutes to half an hour. Run it again. If it is cold agglutinins, all of this will come back to normal. You'll get correct values, a correct MCV, and so on. And call up the clinician and ask for a DCT, ICT rule out an immune process, and your diagnosis is done. We've had about, of the 20 odd that I've seen on counters, I think about 12 or 13 were undiagnosed. They were just picked up on the counters as an autoimmune hemolytic process with an underlying infection in children or lymphoma sometimes in adults. So this bizarre picture actually holds a diagnosis. Next case, very similar. Bizarre findings on your rule of 3. RBC into 3 should be about 2. Wrong, that's 4. 4 into 3 should be 12. That's almost 8, twice. So there is something wrong here. Obviously, your indices are calculated wrongly. Although MCV of 100 seems a realistic figure, MCH of MCH of 54 are all wrong. REW is all by chance. So you may get normal REWs, low or bizarre values. Can't predict that. Again, our histogram is going beyond irregular, sawtooth-like, and going beyond 200 femtoliters. Again, a case of cold agglutinins. So let's leave the white cells and the red cells and come to the white cells. It's a more complex area, so I've picked up some good classical examples to show you. And we know we work better on white cell identification with 5 parts, but 3 parts still have a role in giving you some clue. Important to understand the WBC histogram well before we start to interpret this. So your volumes range from about 40 or 50 odd to 400 femtoliters. And we know we have the lymphocytes, the mid-zone here, and the granulocytes in a 3-part analyzer. And that's where your cells are supposed to lie, your lymphocytes, your basophils, the monocytes, and the eosinophils, and then the neutrophils. Now, if these are volumes, and this is the biggest cell, what is it doing in the center? We also know that the eosinophils are slightly larger than the neutrophils. So why are they behind and the neutrophil ahead in volumes? So the answer to this lies in that the cells are not counted as we see them on the smear. A lye solution acts on these cells and crumples the cytoplasm onto the nucleus, and does not depend on the size of the nucleus, depends on the density and the sponginess of the nucleus. When the lyse acts, this nucleus contracts more than even a neutrophil, and so becomes smaller and is plotted here. I'll show you the values there on the next slide. Remember, eosinophils and monocytes, although being of large volumes, are actually in the middle zone. So before we add the lysing reagent, that's the sizes of the 5 population of cells that we have. So no surprise, Monocytes-II visibly also are large, 12 to 20 microns. So we expect them to be on the extreme right, but they are not, like you saw. And that is because after the lysing reagent is added within the instrument, the volumes change. So monocytes now become an intermediate volume with basophils and eosinophils. Neutrophils hold the largest volume, so they are plotted to the right. So coming back, these two shrink to very small volumes and are plotted here, and this remains a large volume and is plotted on the right. So just look at the normal, we looked at the RBC histogram earlier. Let's go to the white cell histogram. Your lymphocyte peak, the mid peak or the mid segment, and the granulocyte. And the differential reflects these values very well. Lymphocytes are about 26.8%, granulocytes about 66%, and about 6% is monocytes. One mistake to avoid is the height does not matter, because if this height is more, the number of cells is much less. This height is less, but the number of cells is more. So it's the area under the curve that is more. So area under curve here is approximately this much, while area under the small appearing curve is actually more. So this is what you need to look at, and not only the height. So in this we see it's a predominant population of granulocytes, like in all of us normally. Monocytes percentage or mid population is very small, and lymphocytes is the other cell population. Let's see variation in these in the next cases. A word about eosinophils and monocytes, the way they are dealt with in the instrument and where they are plotted. So before I go on to that slide, important to say that a lot of people will vouch for that they have to fall in the mid zone. They don't. They don't follow these rules regularly. You can't predict which sample will, which will not. So if you're suspecting monocytosis or eosinophils on the basis of a look at a smear, your histogram may not reflect this at all sometimes. May or may not. Quite often 3 parts will fool you. Let's see some examples. Eosinophils are 12. I've used 5-part scattergrams alongside to be sure of the numbers, so that when I explain it will be easier. So eosinophils in this case on a 5-part analyzer are actually 12%. This is your eosinophil population, very distinct. So in this 5-part, which is VCS plot on the Beckman Coulter, these are granulocytes, these are lymphocytes, these are monocytes, and these are eosinophils. So I see a distinct population of eosinophils very clearly delineated on the 5-part analyzer, which gives me a good percentage, 12%, corresponds with my smear. But what does my 3-part the 3-part histogram show me? Now this is the 3-part of the same analyzer actually, the impedance improvement. It shows me a lymphocyte peak and a granulocyte. Does not show me a mid population spiking out to say there are eosinophils. So not seen. Next case, eosinophils are 45%, a bigger population here now. But what is the 3-part histogram showing me? Lymphocytes and 1 peak. A bit irregular but joined. So this seems like granulocytes together. But as we can see on a 5-part, the granulocytes are less and more population of eosinophils is seen, not picked up in the 3-part. Monocytes again will be inconsistent. Let's see one case. 12% on the 5-part analyzer. So where are the monocytes? Here are the monocytes on a 5-part. They were supposed to come as a spike here, not there at all. Just some interference here, which you will probably ignore. So not much of monocytosis seen in this slide. While this one, which was a case of chronic myelomonocytic, you have a monocytic population very distinct here on the 5-part. And here, this is a minor lymphoid population corresponding to this. The granulocyte population is here corresponding to this cloud. And you do get a monocyte peak in this one. So what you saw was no monocyte peak here, but suddenly a monocyte peak when the number is more. And I'm not sure if this was because of just the number being more, or that this is a malignant monocyte, which may give you nuclear morphology characteristically different than a normal monocyte. So the point I'm making is eosinophils and monocytes are not very, very reliable on 3 parts. You have to take care and look at a smear in these cases. And sometimes if there is an eosinophilia, and there's a disturbance in the peak that you can identify, your percentages may not match. They'll match very well with a 5-part, but not with a 3-part. Your smear might show you 70%, and your histogram pattern may show you an interference which is minor. So a case with the Plasmodium vivax gametocytes that we saw about in 2003, 18 years back. It's an old histogram. So here, everything else seems fine except for anemia. But here on the WBC histogram, we noticed an additional hump, an additional irregular hum coming up, merging, going down, and then the granulocyte peak was normal. This was in the morning, I think 8:35 years. We reported that then the patient had lots of gametocytes, plasmodivided gametocytes, some schizones. He reported that he was given antimalarials. Evening, we got the sample again. This had disappeared, and on the smear, only occasional gametocytes remained. So this interference was because of the gametocytes, because they have a nucleus-like structure. They were masquerading as white cells, but because they were not normal white cells, whatever structure was developing at least gave an irregularity in that area. So we didn't know this till the repeat smear was made, and we went back and looked at what could have been the challenge, and this was the irregularity that we saw in the first one, not there after treatment. So a lot of studies have been done, especially in 5 parts on the way Plasmodium vivax behaves or falciparum gametocyte schizones. They can fool your white cells or cause problems in the histograms. Lots of mimics of McDonald, and we know Nike. Lots of these are there. Let's look at some false high counts and the cause in the histogram that can be picked up. So this is a series that we had of 14 patients collected over, I think, 2.5 years now, varying hemoglobins. But I want to focus on the initial WBC counts. There are leukopenic cases, yes, but most of them have normal counts. Some have leukocytosis also, but these are all wrong. So we got calls from the clinician that count does not match with the last report or the day before, etc. And the numbers that you see in brackets, sorry, the numbers that you see in brackets here is the number of times this count was off the actual count. So in this case, the actual count was 400, reported as 3,100 by the counter. 2,900 actually, 3,300 by the counter, 33,000 by the counter. 100 here, reported as 4,000. Now, why are these counts so low? Because these were patients actually from critical care areas. About half of them were post bone marrow transplant. Some of them were AMLs on chemotherapy, and 1 or 2 on solid cancers, especially CA breast, on chemotherapy. So they had low counts. They were being monitored daily. That is why we got alerts quickly that the count is not matching with yesterday's count. Our own delta checks failed. So when we looked at this, what was the problem? First, let me go look at the histograms, and then we'll go back to the answer. So let's, when we started finding the cause, it wasn't probably in the first 3-4 cases, we couldn't figure out much. As we built up this series, we could find a pattern. That's why I say it's important to look at the patterns that you're encountering while seeing your cases. So these two are normal histograms on top for comparison. Now, between this initial sample, TLC is 3,200, repeat sample, actual TLC is 500, matching with the slide. The difference is in the histogram. And I'm going to take you through these 3 histograms, a very straight ascending peak, very abrupt ascending peak. Here, the ascending peak is angulated and sloping, more close to the normal ones. And therein lies the answer. So why was this happening? So what was happening in the WBC estimation? Something was interfering and causing this abnormal count. Something was interfering, causing this abnormal histogram, and increasing the counts artifactually, spuriously, falsely. This was actually fibrin clumps. So all these patients that I'm talking about were having central lines or difficult veins because of chemotherapy. So most of them were slow draws, either from central lines or a direct draw from the syringe, but slow draws from the veins. So they developed microclots and fibrin. And fibrin appears like this as threads. So you can see these amorphous threads. Some of these clusters, the big ones will appear in the tail because of the weight and specific gravity, but some of them may get mixed in the sample. And fibrin is pretty sharp. It will cut your RBCs in the smears. Important to look for these findings if you see a histogram like this. And I think there are unlicensed RBCs can also interfere in this area, but the sharpness that we've seen is typically because of fibrin clumps. One more point, these may be inconsistent. So you run this sample again, you may get a count of 6,000, falsely high again, depending on how much of fibrin gets into your WBC aperture. And that's one of them in a high par at the end of the tail end of the smear. Okay, another case that gave rise to artifacts, but you can see in the histogram what was happening. This is a patient with burns. So hemoglobin is 18.7, there is hemoconcentration. The problem we had was the platelets were 7 lakh, but on the smear, We did not have 7 lakhs, we had about 2 lakhs. So what had happened? Some of these fragments that are pointed on the arrow were actually red cell fragments. So because of extreme burns, he had 90% burns, there was pyropoikilocytosis. So the burns actually budded off or made many of these RBCs spherocytic and small, with budded off small fragments of the size of platelets. So some of these are actual platelets, the rest are all red cell fragments. So these small fragments, being of platelet size, were counted as platelets by the counter. So the counters are never wrong this way. They count what they see or what they get. It is for us to interpret what they're getting. So let's look at the histograms here. WBC histogram is fine. Your RBC histogram and the platelet histogram. Platelet histogram is irregular because of varying volumes of these fragments and not touching the baseline. The RBC histogram at the starting is not starting sharp. It seems to have a shoulder. So what I've done is cut the histogram in two and join them because platelets and RBCs are counted together and they join perfectly. So it is the RBC fragments which are small which are actually interfering in the platelet count. So you're overcounting these fragments as platelets while the actual count is low. So in these cases, obviously you require a smear to sort out. Now, going to leukemias and WBCs, let's look at what is normal. Now, we already saw what is normal, but to make sense of a leukemia, we understand its normalcy even better. That's a train in the UK. We can expect limited number of passengers inside. That's a train from Bangladesh, all over. A class in progress, orderly, small group discussion going on. This class, disorderly. So I want you to imagine leukemic cells as disorderly students or a train packed with passengers, crowding and not following rules. That's the basis on which we work on leukemias in a histogram on a WBC part. So let's come back to this. Your WBC histogram has three parts, like we said. Your lymphocyte zone, granulocyte or neutrophil zone, and the mid zone. The mid zone almost acts as a connector, just tends to connect the two, that's it. So the lymphocytes are in this zone. Remember this peak. So if I say how many peaks are there, you will say 2. 1 and 2. This is just a connection. It's low, it's not a peak. So the mid population is like that, small population. Lymphocytes and granulocytes, depending on which population is more, will be more. Rises, important thing to notice, this peak rises in its own zone, which is this zone, and falls in its own zone. Then your mid population, granulocytes rise in its own zone and they fall in their own zone. That's the basis of a leukemia diagnosis. Obviously, this is not a leukemia, this is normal. If you remember this, you will be able to suspect and sometimes diagnose some kinds of leukemias. The same thing in a different way. Hill range on the lower side, you have lymphocytes and the granulocytes, and you have the mid zone. So again, two peaks in just a bland connection, almost flat, slightly angulated. If you think of a leukemia, think of Everest. One peak. And we're talking about acute leukemia, not chronic. Think of one peak in an acute leukemia. Remember, this is also dependent on the number of blasts that you may find. So 7, 4, 3, and occasional blast will not cause a change in the histogram. But 15, 20 and beyond will start changing your histogram patterns. So let's try and look at some leukemias now. Normal histogram, normal pattern. Lymphocytes rise in its own zone, fall there. Granulocytes rise in its own zone, fall there. Two peaks, distinct. In this case, what do we see? TLC is normal, so that doesn't give me any clue. Indices are normal, some anemia is there. But if you look at the peak, it is abnormal. Let me go back to the normal peak. So you saw clear two peaks. Here the peak pattern is totally abnormal. So the lymphocyte peak so rises in its own zone but falls in the middle zone or the mixed population. Hardly any granulocytes. So obviously the the differential percentage changes. Minimal granulocytes, the mixed population suddenly increases because that's where the cells are lying, and the lymphocytes also are increased. So this is a case of ALL, acute lymphoblastic leukemia. Now you can actually say these are going to be atypical cell without seeing a smear because of this single peak. It is not following rules. You do not have a distinct lymphoid population in its own zone. It is spilling over to the other zone. Why am I suspecting this to be lymphoid even before seeing the smear? Because of its location. The lymphoid blasts are smaller unless they are of the L2 type, then they may be looking like myeloid. We'll show an example of that. Yeah, not in that, but myeloid one. So this is smallish blast population, hence more close to the lymphoid zone. So you can suspect this to be an acute lymphoid leukemia. Next case. Again, how many peaks? One. Right? So that's Everest, acute leukemia. So a lymphocyte seems to rise in its own zone, then keeps on rising, goes to the mid zone, falls in the granulocyte zone. But again, one composite peak. Position compared to the last one, more to the right. So obviously there's a bigger blast, and your differential is all gone wrong. Your mixed population suddenly says 41. Somebody can argue why not 41 monocytes, but then you should still have your normal lymphocytes rising in its own zone, falling in its own zone. Same for granulocytes. If there are 37 granulocytes and they are normal, they should rise in their own zone, fall in their own zone. If that is not happening, these are abnormal cells. That was AML. The next case is another AML, similar pattern, single peak. So remember, two peaks versus one peak, and you have an acute leukemia coming up. So let's compare. That's normal, that's ALL. These two are AMLs, pretty similar to each other. And like I said, an ALL with the L2-like population may look like this. So our job here on an analyzer is not to categorize the anemia perfectly. It will not. It is not supposed to. But it'll give you an indication. And just go back for one statement to the last slide. It will also give you flags. So here the flags are M2, G1, G2, and the M2 flag in this analyzer meant leukemia or atypical cells. So you have to correlate your histogram with your counts with the flag and then look at a smear and you'll sort it out. So our job here is to say that there is an unusual population coming up, probably an atypical or blast population, and look at this smear urgently. So the purpose of this is to flag it for you, to mark it for you, and the histogram will actually tell you that there is an atypical population to be looked at. Another case, TLC is very high. I think of an acute leukemia first stop. Hemoglobin is 9.2, but 341. Acute leukemia seems unlikely. So look at the histograms now. The WBC histogram is very wide and broad on the granulocyte side. So if you look on the differential, lymphocytes are 4.1. So again, if you look, it's a very small peak of lymphocyte, but it is rising and falling in its own zone still. A mixed population on the rising curve, and then your major granulocyte population, which is very wide. So if you go back to the normal population, the granulocyte peak is like this, till 300 and pretty flat. Here it is going beyond, much beyond 300 and very widened. So you know this is a granulocytic dominant, and with this TLC, this platelet count is likely to be CML in chronic phase. 3 months later, this patient turns up again, and he has clinical features that time of a blast crisis. And that if he has blast crisis on top of CML, where should the acute leukemia cells come up? We saw them coming up here, right? So I would expect a population to come up here, and because the granulocytes are already there, it will actually join. That is what is expected if an acute leukemia or a blast population turns up in this patient. So let's see what happened there. So this part seems okay till here, matches, and then suddenly this part is gone up. So your mid population is rising in this one and joining directly. What do you get? One peak. Right? So that again tells you it's a conversion to an acute leukemia. So this is CML in blast crisis. You can pick this up pretty well on a 3-part analyzer. Another case. Now in this case, I'll probably have to share the diagnosis first. This is a CLL, chronic lymphocytic leukemia, with a sample running dilution. The TLC is very high. Our cell counters limit was 80,000, so we have to run it in dilution. So this is a 1 in 5 dilution. That is where the other values are bizarre and 0. So the TLC was 350,000 in this patient. On a dilution, you see it as 70.6. But let's look at the histogram and the differential. Differential shows me majority of them are lymphocytes, very small mid population, and hardly any granulocytes. If you look at the position, it is right in the lymphocyte zone. We know the cells in CLL resemble the normal mature looking lymphocytes. They are not blastic. So they are plotted very well in the lymphocyte zone. And that tells you the diagnosis, chronic lymphocytic leukemia. So just to compare, normal, CLL. Now the CLL peak and the normal peak is virtually similar, except for the high TLC, right? Because the cells being lymphoid-like are plotted in the normal lymphocyte zone. So the instrument is not going to tell you that this is a CLL, you have to just figure out lymphocyte zone, lymphocyte dominant, leukocytosis, there is absolute lymphocytosis, correlate clinically. So here is a normal one, acute leukemia and CLL. So the blastic population and the mature population does behave very differently. So your orderly cells, orderly passengers versus disorderly, unruly students. They don't follow rules, they will not fall where they are supposed to. Normal, ELL, and CLL. Just two examples on hairy cell leukemia. That's a five-part differential on this. Hairy cells were 44 in this. And on a five-part, this cloud was actually lymphoid. Just expanded a bit. So it doesn't tell me much. So the cells are merged in the lymphoid population, even in the five-part analyzer, and slightly extending it beyond. So in the three-part histogram, all I can see is a lymphoid population. That's it. So this has hairy cells and the lymphocyte mixed. You cannot make out. Next case, this had more hairy cells, 53%. Sorry, there, and they were plotted in the monocyte zone in this case. So these are granulocytes, these are lymphocytes, and we could see the distinct hairy cell population plotted in the monocyte on a five-part, and the three-part did show an interference here. So it is, you're not sure all the time on the three-part, but in this one, because that's your lymphoid peak coming down, and this is your mid, and the mid shows a bit of elevation. So some interference, which you are seeing on a five-part better, but at least something on a three-part. So in which cases can you get false interpretation of histograms? If you have stored samples where your neutrophils can be counted as monocytes when they become vacuolated or granulated, if you do not correlate with flags or numerical values, if you are not studying the peripheral smear when required. So in a case where I'm seeing abnormal histograms, I would rather want to see the peripheral smear, definitely. If you're not correlating with the clinical profile, like the patient with burns, if you do not look at the smears, do not know the history, you'll make mistakes in interpreting even that histogram. And most importantly, if you do not use our freely available two-part analyzer between our ears. So the last part is platelets. Not too many examples here, but some of them the common ones there. So I'll just share some patterns with you here. So the normal platelet histogram is this: rises, falls, and below 25 all our platelet counting is done. MPV is 10.5 in this case. Normal is about 7.5 to 10.8. Different labs will take their own. So that's a normal MPV, normal platelet count, normal histogram. Now these two examples here actually show you, in fact these three, but these two more prominently, you can have a normal histogram even with thrombocytopenia. So platelet count is 81,000, 1,09,000, but the histogram seems normal except for slight tailing on the higher volume area towards the end. And that is how your MPV is increasing, 9.1 versus 10.2, because you have some more giant platelets. Thrombocytopenia usually will have regenerative large platelets, and that will push up your MPV a little bit. But in this case, your platelet count is reportable. So a lot of people say, when do we need to see a smear? So in this case, if your platelet count is low, there is no flag for clumping, there is no interference at the tail end, platelet histogram is ending in the zones there where it is supposed to, your count is likely to be true. You may want to see the smear still, but you're not likely to change your count. The more you see interference on this side, which means more giant platelets, you're likely to do the incremental count of platelets. So this 1 lakh might be corrected to 120 and so on. Notice between these two, MPV is rising. So a difference of 2 femtoliters because now we have a higher volume platelets more in the tail side. So your histogram and the MPV will reflect each other, and the counts will also match. So important thing from this slide is you can have perfectly normal histograms even with thrombocytopenia. And if they are perfectly normal with thrombocytopenia, that thrombocytopenia is more likely to be true and more matching with the peripheral smear findings. Next case. The top is the same histogram, normal for comparison. These two cases show marked thrombocytopenia, 20,000, 11,000. Now look at the histograms. They are not your normal pattern at all, down and irregular. This could also be clumps, irregular clumps, or varying size large platelets, but thrombocytopenia. So this is true thrombocytopenia, low amplitude, not a normal histogram. While on the slide we saw last, higher counts, but a normal histogram. So as your platelet count dips, you come more close to the baseline because you don't have enough cells of that volume. An interesting condition to end with. Platelet count is 361. That's a normal one for comparison again. Now, these two cases, have a look on the counts. Platelet count reported by the instrument was 58,000. The manual count was 90,000, 90,000, 90. Mean platelet volume is 13.6, 12.3 here. There's a good difference of about 32,000 in the platelet count between the manual and automated, and here almost 60,000. Right? Also look at the cutoffs, the thresholds. 25 here in a normal one, about 22 here and 20 on this one. Moving thresholds. So what has happened? This patient has high volume platelets and high volume platelet. It is continuing, not coming down at all. So the platelet volume is very, very large. In this case, the large volume platelets are only this much, very small. Here, they start here, they are very, very high volume and they don't stop. Same with this case. So in this case, what is actually happening is, beyond this, the instrument is not counting. Because the distribution is such that threshold is moved inside, the instrument is counting the platelets only till this area, and the rest is being counted as red cells. So that is why we're discrepancy in the manual and the platelet counts. So this condition is called macrothrombocytopenia, in which your platelet histogram does not touch the baseline, remains in the high volume zone. There's a lot of inherited syndromes related to this condition. The Indian variety luckily has more of asymptomatic patients. So that's your area to look at. Your histogram has not touched the baseline and still continues in a high volume zone. That's how the smear will look like. These are both normal smears in two different patients. And if you look at the platelet size, you can look at it's almost dot-like, very small. While in these patients, look at this, except for this lymphocyte, the platelets are large. This is huge. Some of them are bigger than red cells. So this is what is causing the problem here. The big platelets are being counted as red cells. I'll end with a quiz. Only I'll have to answer probably. Platelets 1,21,000. The second case was 71,000. Manual is 130. But the MPV is similar. How do you explain this? We say these, you can see these platelets, the large volume platelets are less. Here the large volume platelets are more, much more, but the MPV is still same. So that's the fallacy of three-part analyzers. A five-part or some analyzer doing optical counts will give you an accurate MPV even on this patient, which is obviously higher. But this is still on matching with the other one, because beyond this threshold, these platelets are going to be counted by the instrument as red cells. Red cells are in millions. So a few thousand platelets there will not affect their count, so it doesn't matter. But your platelets will be undercounted. That is why in this case, till here, it counts the platelet as 71,000, gives that report. All other platelets which are of this size are going to be counted as red cells. And they are going to be put into the red cell count. And obviously, these large platelets do not then contribute to the high MPV. That's where MPV remains stuck at what it could calculate till this level. I think that's all I have. Thank you so much. I'll be happy to answer any questions if there are.
Thank you so much. Excellent presentation and very crisp, clear, so practical. And I think among all the counters, the two-part counter is the most important one. Very, very nicely done. I think this is something which everybody should listen to again and again. How much can we be derived from the three-part and how to understand every bit of it, from the discriminator to every bit of it. Wonderfully done. Excellent, sir.
Thank
Let
you,
me
sir.
just see if there are any questions. If anybody in the Google Meet would like to ask a question, they can just unmute and ask straight away. I'll just check up on the YouTube. Dr. Pratik Shivappa says, very nice, sir. Excellent presentation. Brilliant. Before we stop, before we conclude here, I would request you to come back with the five-part one. That would be wonderful. The way you are teaching is too good. It's so practical. It's just not have any theory into it. Exactly what you would be doing in the lab, how to see things and how to analyze every bit of it. It's wonderful.
Thank you so much, sir.
Brilliant. Excellent. Just wait for a minute to see if anybody would like to ask any question. Dr. Neetu Sanjeva says, sir, please repeat the malarial parasite interpretation.
Okay, I'll do that. Is my screen visible?
No, sir, you have to share it.
Okay, do that again. Right. Is it
Yes, sir,
visible?
now it's visible.
Right.
Yeah, just
I'll just go to that case. In this case, this patient had Plasmodium vivax gametocytes on the smear, and the smears being nucleated. Now the RBCs are anucleate, but with the gametocytes, it sees when the lyse acts, it sees these cells as nucleate cells. So when they go into the channel, they have now put they have left the RBC and now put into the WBC channel. And because they are not normal lymphocyte-like, neither they are granulocytes, they're just abnormal population of cells appearing as WBCs. The instrument plots them separately. So once the treatment was given, the gametocyte disappeared and this came back to the normal pattern. Neetu, if that is clear, I hope.
Yeah, Dr. Neetu, if you're there, you can unmute and talk straight away.
Yes, sir, it's clear now, sir.
Okay, thank you.
Okay, thank you, sir.
Once again, Dr. Kakkar, brilliant presentation, very wonderfully taught, very wonderfully taught.
Thank
I
you
would
so much.
request you to come back for that 5-part
Sure.
and artifacts in hematology. Everybody wants you to
Right.
come and speak on that.
Okay.
There have been a lot of queries and there have been a lot of mails which I've been receiving to request you to speak on that. I think that's your
I'll do that,
you have a
sir.
lot of publications in that, and people want you to speak on that.
I'll do that, sir.
So
Sure.
maybe in December we can discuss and finalize a particular date which is convenient to you,
Sure, sir.
and we'll have these 2 lectures. I just let me check the YouTube. Yeah, there is a I'll just paste this question here from YouTube into the chat box here. Now, Dr. Ratik says, sir, in dengue, sometimes basophilia is shown in 5-part, and we need to correct it. Like, is there any relationship of basophilia with dengue?
I don't know. Really, I don't know. In dengue and 5-part estimation, I have not much experience now. Atypical lymphocyte interference does come, but I'm not sure about basophilia.
Right. Dr. Vikas Dubey says, excellent presentation, sir. Very informative and very comprehensive.
Thank
That's
you.
true. I don't see any comments or questions anymore, sir.
Okay.
Before I conclude, thank you very much for taking out time from such a busy schedule and teaching us so nicely the 3-part analyzer. And we request you to just share your PDF. I'll put it up on the Google Drive for everybody to go through that. And I'll get back to you for a particular date so that we can come back with the other 2 presentations at your convenience.
Right.
Thank you so much, sir. Good night. Take care.
Thank you. Good night.
Thanks everybody for joining in here as well as in the YouTube. Bye-bye. Good night. Take care. Bye.